a demand, an initiative to go out and ask for help. Thank you.
Christine, you had some?
Hi. Christy Bright, New York University and Bellevue Hospital in New York. What I really appreciated about the panel, starting with Dr. Porter's wonderful blueprint, sort of organizational overview of what implementation science can be, and then starting with each of the unique examples of a community-based implementation, a educational-based and also the clinic-based implementation strategy. I have a question for, I guess, the panel as well as all of us to consider. What I've noticed about the sort of historical trajectory that we've taken in the United States is that a lot of these efforts have been very sort of, what's the word, spatially and sort of organizationally siloed in various ways. And I'm thinking specifically about the Promotoras project and how you are then sort of thinking strategically about bringing those individuals into conversation with your providers, and then also conversely how your providers are also receptive or sort of having a conversation, and I'm thinking specifically of Rosemary's comment about you know, specifically what kinds of needs need to be filled in the clinic vis-a-vis the patients and the populations that you're serving. And it's kind of a grand question, but as we look for models that can be effectively integrated and moved into other settings, can we not perhaps repeat some of the same sort of organizational trajectories that we've made in the United States, if you know what I mean? And sort of what are your thoughts about how to sort of grow those things up in settings where, for example, Dr. Samia and I were talking about this. She is just, in many ways, one person, she is an advocate, she is also a physician, and how can she together, interface her sort of relationship with her community of survivors and her relationship with her clinic in order to do that more quickly, because she wants to do that more quickly than the 50 years or so that we've been sort of seeing this evolve in the United States. So just a question for I guess all of you.
Who wants to take that?
Well, I'll take a stab at it. I think that's a very interesting question, and unfortunately, these things do take some time, and certainly one person can make a big deal of difference, a great deal of difference. I think we heard that this morning when our advocate was speaking about the Komen Foundation. And I think that what we have to do is, through the process of talking with people, we have to gather our constituents who agree with us, who want to support an effort, support a program. So the thing to do is to, everywhere you go and talk to people, find somebody who is of like mind, who will work with you. And it's still not going to happen overnight, but it can happen more quickly than this sort of 2-year trajectory that I've been talking about.
I guess what the point that you're making is that there should be a continuous crosstalk between those who need, those who provide, and those who evaluate. This continuous crosstalk will allow this system to evolve continuously to get into better and better outcomes. I guess we have run out of time now. I hand over to Dr. Ben Anderson for his comments.
So we're going to do the question one more time from the beginning of the session. Carol will bring that up. While she's doing that, we will reconvene as soon as we do this question in 20 minutes. That will be 20 minutes till 11. But the question is, multidisciplinary breast cancer care, A, is unavailable in low-resource scenarios, B, requires subspecialty training, C, is not relevant in low-resource scenarios, D, all of the above. And there's a definite possibility that this question is one that Gabrielle Kane was talking about, that it really isn't a particularly good question, but it gets people thinking. Go for it. Huh, that looks quite different. Okay.